Getting ready for your surgical exams, you're in the right place. This is going to be the essential, focused review you need. So, here's our game plan. We're going to start with the absolute baseline numbers you just have to know. Then we'll jump into the tricky clinical scenarios, what to do when sodium is too low and when it's too high. And we'll wrap it all up by showing you how to apply this stuff in real life.
First things first, let's lock in the fundamental numbers. Honestly, these are the bedrock for pretty much every sodium question you could possibly face.
Okay, this is it, the big one. The normal range, 135 to 145. You've just got to know it cold. Everything we're about to talk about, it's all defined by whether you're inside or outside these two goalposts. And what about what your patient needs every day just to stay level? It's about 1 to 2 milliequivalents per kilogram. This is a super key fact when you're calculating maintenance fluids, so definitely don't let that one slip your mind. Okay, so what happens when things go wrong? Let's tackle our first clinical problem, hyponatremia. This is what you're dealing with when those sodium levels dip too low. And believe me, you'll see it all the time on the words.
The official definition? It's as simple as it gets. Anything less than 135, and you're officially in hyponatremia territory. Easy enough, right?
You're going to see this a lot in patients who are basically waterlogged from organ failure. But, the one that really trips people up on exams? It's SIADH, the syndrome of inappropriate antidiuretic hormone. So let's zoom in on that one. Now look at this, because this is where it gets really serious really fast. The symptoms just escalate so dramatically. You go from a bit of confusion to nausea, but once that sodium drops below 125, we're talking about life-threatening events like seizures and even coma. Okay, here is a massive tip for your exam. If you see a patient with low sodium, but they look like they have a normal fluid volume, we call that euvolemic hyponatremia, your brain should immediately scream SIADH. That combo is a dead giveaway. And check this out. It's a total paradox, right? The body is holding on to way too much water, so the blood gets all diluted, low sodium, low osmolality. But at the exact same time, the kidneys are just dumping sodium, so the urine is super concentrated and salty. It's wild. So how do we fix it? Well, there's a logical progression here. First, you've always got to find and treat the root cause. For SIADH, the absolute cornerstone of treatment is restricting their water intake. You only bring out the big guns, like hypertonic saline, when things get severe and neurological.
All right, let's flip the coin. What about when the sodium goes the other way, when it gets way too high? That's hypernatremia.
And just like before, the definition is super straightforward. Anything over that upper limit of 145, and you're dealing with hypernatremia.
So what's the big picture here? It pretty much all comes down to one thing: water loss. The body is losing more water than sodium. It doesn't matter if it's from not drinking enough, sweating buckets, or a condition like diabetes insipidus. The end result is that the sodium in the blood gets way too concentrated.
And the patient? Well, they look exactly how you'd expect someone who's really dehydrated to look. They're incredibly thirsty, their mouth is dry, their skin turgor is poor. And just like with low sodium, as it gets worse, the serious neurological symptoms start to show up.
Now, listen up, because this is probably the most important safety point of this whole talk. When you treat this, you have to go slow. The goal is to replace that water they've lost, but you have to do it over 48 hours. If you go too fast, you'll cause a massive fluid shift into the brain cells, and that leads to cerebral edema. It's incredibly dangerous.
Okay, let's start putting all these pieces together. How is this actually going to look on the wards? And more importantly, how is it going to look on your exam?
This slide is absolute gold. It's the classic head-to-head you're going to get asked about. Just look at how everything is the complete opposite. SIAD, dilute blood, concentrated urine. Diabetes insipidus, concentrated blood, dilute urine. Nailing this difference is key. And here's another gem for figuring out kidney problems. A really low urine sodium tells you the kidneys are actually working fine. They're just desperately trying to hold on to volume because of a problem somewhere else. That's a pre-renal issue. But a high urine sodium, that means the kidneys themselves are broken and can't hold on to sodium anymore. Okay, so you've nailed the diagnosis. What's next? You've got to pick the right tool for the job. And in this world, that means choosing the right IV fluid. It's an absolutely critical skill. Think of this as your go-to cheat sheet for IV fluids. It breaks down exactly how much sodium is in each bag and whether it's isotonic, hypotonic, or hypertonic. This is the info you need to pick the perfect fluid to fix either hyponatremia or hypernatremia.
And here's a little clinical pearl to keep in your back pocket. We use 0.9% saline or normal saline all the time. But if you give too much of it, you can actually cause a whole new problem, a hyperchloremic metabolic acidosis. So because of that risk with normal saline, if you're resuscitating a patient or they have big electrolyte losses, a more balanced fluid like Hartmann's solution is often a much better choice.
All right, final pop quiz. Let's put it all together. You have a dehydrated patient with a high sodium level. They need fluid. Looking at the chart, which IV fluid has no sodium and is perfect for giving them the free water they need? You got it right. You're linking the diagnosis directly to the treatment. The answer is 5% dextrose. Nailing that connection, that's exactly what you need for the MRCS.